just to reiterate what Claire has already said, but I think needs to be said just as loudly again and again and again. The national programme, the 5-year forward view, is just the areas that we're investing in. All the other things that we're not investing extra money in still need to be looked at, still need to be developed. So, you know, we don't want people to go away from here thinking, oh, we can ignore eating disorders in adults or personality disorder or whatever. So please do go away thinking, you know, this is just simply the focus for the extra £1 billion that we're working up to in adult mental health services by 2021, extra £1 billion investment, and 1.4 billion over a period of 5 years for children. Now, I'm going to talk about some parts of what we're doing, mainly around children and psychosis, not both together, but children and psychosis. And then I'm going to say something about what's happening with the patient safety programme, which the Secretary of State has started and CQC and NHSI are now leading. Okay, so for kids, Claire's already said that we're aiming to see 70,000 more kids. Well, by the end of this year, we will have achieved half of that. That's now, you know, as Claire said, you know, we're going from 1/4 up to 1/3. So 70,000 kids is 8% increase. It's not huge, and that's you know, a sizable investment, you know, to get people, but it's to get to those children evidence-based treatment. So the investment might seem disproportionate, but it's to up our game. And so far, so we've got 70 new or expanded teams for eating disorders. Now, as Claire said, I visited her eating disorder service and I met a mother there and separately a child, and their stories were fantastic. So the child comes in, she sits down, she's 17 years old. She came into the service about 9 months before. When she got to the service, she was seen within 3 days, and she had treatment started within a week. Okay, now if I go back just 2 years, that could have taken a year. Yeah, mother comes in, mother says, you know, she'd been taken her daughter into private services, and for the last year they'd got absolutely nowhere. Went to the GP said, have you heard about this new service? So off they went down, and her daughter, who by that stage was down at a BMI of about 14, was admitted very quickly for a short admission to a paediatric unit where the eating disorders team worked with the paediatricians. It was 2.5 weeks. She was back out, and by this stage, her BMI is back up at 20. Okay, so really good news stories, seen really fast. Now, on top of what we're doing for kids, there's a green paper, which the Secretary of State for Health and Social Care and Education put through, and this basically has 3 key components. One is that there will be a designated mental health lead, rather like you have for special educational needs. You've got a SENCO. Now we will aim within 10 years to have every single school will have a mental health lead, and it'll be a senior person. Second, that we will get groups of schools together and we will serve those schools rather like the way that IAPT works, but those mental health support teams will work into those schools alongside the new mental health leads within the schools. Okay? Now, CAMS will supervise, will come in for diagnostics, that sort of stuff. So it's going to be a much more connected service than currently IAPT has been. And we will aim to have a series of pilots over the next few years where, alongside this, we're going to bring the waiting time down for CAMS to 4 weeks, okay? And we're going to find out how best to do that and what that costs. Now, this whole program is going to work up over a period of 10 years because this is a new workforce, And this effectively is going to double the size of the workforce working with children's mental health. There'll be 8,000 people working this alongside the 7,500 that we've currently got in CAMS. Okay, can talk more about that. I'll briefly say, because I think you've probably got this, early intervention, which it is for children, it's from 14 years upwards. We've got a waiting time. Claire said about we haven't quite got there with nice concordant care, but we are doing well in terms of the number of people that we are seeing. So I'll skip that. Individual placement support, again, Claire has said something about this. We are very, very keen to try and get across all early intervention services a really effective individual placement support. This is a type of supported employment, and all we mean by that is there are two ways of doing this. You either train people and then place them in jobs, doesn't work so well, or you put people in jobs and you train them on the job, and that's what this is. So it's, instead of training and placing, we place people and train them, okay? So it does work better, and this is completely nice concordant. We did the systematic reviews around this. Yes, training people and placing them might be useful for some, but this is better for most. Okay, now moving swiftly on, the Secretary of State, as you probably are aware, has had a 5-year programme, 5 years effectively, since mid-staffs. He came into his post when mid-staffs hit and was horrified by the fact that it turns out every health service in the world harms 10% of the people who go into it. And mid-staffs, he thought, well, maybe this must be a one-off, surely. And David Nicholson said to him, I'm sure you will find more places like this all over every health service in the world. But he went on a mission, and he's been on a mission with physical health for 4 to 5 years. And about a year ago, he asked us if we would help him do this in mental health. So what he now does is that he goes around trusts. So goes to 2 every 2 weeks, mental health trusts, and he will go usually with me or with David Fernley, who's the deputy, my deputy, or others in the team. And we'll do a nice talk for everyone about his experience, his journey of patient safety from mid-staffs all the way through to now. And then it's my job to come in and say, how does that work for mental health? Most people are sort of going off by the time it gets to me, but alongside this, every week, meet with the Secretary of State, CQC and I go through all the trusts that are currently what we think of as struggling with patient safety. So we've gone through all 54 trusts. We think there's about between 10 and 12 at any one time who are struggling to get patient safety right. We're going to visit them. So I've been off to Norfolk and Suffolk, who are struggling, going off to see Isle of Wight. And we run through those with the Secretary of State so that he understands exactly what we're doing. So he's very, very hands-on. We are getting funding for those trusts. But in doing this, we said to the Secretary of State, CQC, NHSI, NHSE, surely we need to have this for everyone. Let's have a quality improvement programme across mental health. And I think Claire and I are both completely signed up to us having 50% of all our trusts reaching outstanding within the next 5 to 10 years. And we will do this, which I'll come to in a minute. Yes, this is what Paul Lelliot calls his virtuous circle. At the moment, what tends to happen is that CQC give their report, NHSI come in and go, do what you're told, yeah, and performance manage you. That's it. What we want to do is to bring in quality improvement expertise and make that a much more meaningful engagement and conversation. Now, quickly turn to out-of-area placements, which is one of the key things in the patient safety program. So it's not just what the CQC identify as patient safety and how well led you are. Those are two key domains. But it's also out-of-area placements, which you've done really well with over the last few years. But not everybody has. There are still trusts who are really struggling with this, and this is no fault of their own. It's a systems problem about how we run acute and crisis care. So we intend to address this, but look in the red box. That's how much money we are spending nationally on acute out-of-area placements, 100 million quid. If we could put an end to that by bringing down everybody's length of stay, that money should be yours to spend on patients. Running home thinking, God, we're rich. Okay, I won't go on about this. It's all about whole system management. Think of acute and crisis care as a motorway. I know it sounds dull, but it is. It's a bit like running a motorway. If you have one lane blocked, the whole thing goes into crisis. So it does mean really, really rigidly controlling patient flows and making sure that patient safety in that process, alongside your patient flows, is maximised. Yeah. Now, that takes a lot of doing. I failed in Sheffield for 5 years before we worked out how to do it. But there are 12 trusts, all of whom are now committed to coming down and helping other trusts solve this problem. And that's our map at headquarters. We've got the map on the left. That's the heat map where out-of-area placements, the darker it is, the more difficult. And the map on the right, the green is where we've already been. The yellow is what's coming. GIRFT, Getting It Right First Time, is a program that we don't run, but Claire and I asked GIRFT if they would have, well, I think it was insisted that they must have mental health in their program. They've got lots of orthopedics and God knows what else. But there are 3 areas that they are going to be working all around the country, setting up the metrics and the patient flow and the patient pathways to help trusts start looking at the 3 key areas of acute and crisis care, of complex rehabilitation, and of Tier 4 acute and crisis care in CAMS. Each of those areas has a pot of gold at the end of the rainbow. And the deal with GIRFT is that if you bring those out-of-area placements back for acute care, crisis care, for locked rehab, and for Tier 4 CAMS, you keep the money, okay? And we think that there's possibly between 200 and 400 million pounds worth of savings in that. The final bit, which Claire did say about suicide reduction, we've got, starting this April, we're helping all trusts, initially, not all together, there'll be 8 STPs to begin with, and we're going to be helping you to bring your suicide rate down by focusing quality improvement methods on 3 patient groups, all of which overlap, but they're the big groups. So there are, out of 5,000 suicides per year in England, 1,200 happen in mental health services. That's come down from just short of 2,000 15 years ago. Yeah, so it's gradually come down. So we are doing good things, but we want us to do more good things. And as you know, there'll be a 0 suicide aim for inpatients. Alongside that, we want to look at people who self-harm. In the year after you've self-harmed, after someone's self-harmed, the risk of dying by suicide is between 70 and 100-fold greater. It's the biggest predictor of later suicide. And the third group, which is the most challenging, most difficult to get to, are the large group of largely isolated men who don't engage with services and don't talk much. And that's a real challenge. So that's what we'll focus on, and we've got some money to invest in that. It's 25 million, it's not a huge amount of money, but over 3 years, let's try and get that suicide rate down. So that's it. whistle-stop tour. I think we've covered nearly everything between us, haven't we? Yeah. Thank you.
Right, thank you for that. Fascinating insights and to see how local echoes of issues we're dealing with are played out at national level as well. We've got this fancy system for questions. I'm going to read out the questions to assist those with visual impairments. I think we've got about 15 minutes for this, thereabouts. So the first question, where will the new workforce come from given current challenges with recruitment? Who wants to take that?
I'll start, but
There's a mic.
Thank you. Is it on?
It
Can you
was.
hear me? Do I need to? Oh.
Can you?
Is it on?
Yes, it is now.
Thank you. So there are some real risks to delivery, which I was hoping would come out in the Q&A bit. And if you were to ask me what gives me my most sleepless nights, and probably true of all of my colleagues and of you locally, it would be getting the money through to providers and making sure that turns into more and better services. And even more than the money would be workforce. So I think it's our biggest risk to delivery. Obviously, you will know that we did some modelling of the national programme, which said we need approximately 20,000 more staff in order to people all of those services in those 12 blue boxes and a few that aren't actually mentioned in those boxes. So it's a big expansion agenda, just at a time, I know, when funding for training's changed, and that's been very controversial, when Brexit is playing out and we're not quite sure how, and when I think the mental health narrative on a bad week can be unremittingly nihilistic. And although I don't want us to be unrealistically optimistic about mental health, I know that mental health services make a huge difference to people's lives in terms of recovery, independence, and when they work well, they make an extraordinary offering. And I don't think we get that out there enough, and we mustn't be self-congratulatory, but why, oh why, if you're a mum returning to work and wondering, with a great skill set and wondering what you might do, or a young person leaving school, would you choose mental health if all you're hearing is unremittingly how awful it is, when that's not the lived reality, I think, for many people who work in the services. So workforce is the big thing. We are looking at national programmes for trying to grow the workforce, such as the IAPT workforce. We're working very closely with HE on the nursing programmes. There is quite a worry at the moment that many directors of nursing are sharing in mental health around graduate nurses, second graduate nurses. Something like 27% of the nursing workforce in mental health are mature students. They're people who have a first degree, you know, went into banking or thought they'd be geographers or town planners, find they don't like it, and at the age of 27 or 28 think I'll retrain as a mental health nurse. Well, are you going to do that if you're going to have another 50 or 60,000 pound debt at the end of it? So we're working with the chief nurse and others to look at some national programmes that can head off some of the big risks. But the thing I would say is it's a very permissive environment for creating new roles. Right across the country, your workforce pools and opportunities will be different. So when I go up north, quite often they say I have a problem with doctors. Not a problem with doctors, problem getting doctors. Maybe they do also have a problem with doctors, I don't know. Whereas in London, we have a real problem getting the nursing workforce in. I don't know if you want to say anything, Tim, about the NHSI retention programme and new roles. You have a great EIP idea.
One of the things that we're working on is retention, helping people stay. I think we're also looking at productivity so that we can address some of the shortfall by helping people work smarter. We do want to grow the workforce by creating new posts, and that means churning out more nurses and so on, but that takes time. And as Claire said, we're also looking at new roles. So we're keen to see pharmacists take a more prominent role out in community teams, for example. We want to see physician associates, nurse associates, But a key one, and we've got agreement with Health Education England to do this, is to set up new types of posts like early intervention workers, where we train them, say psychology graduates or peer support workers who want to do this, that we train them in basic evidence-based interventions, like you can train people to do family interventions, for example, relatively easily. But you can also train people to do some of the physical healthcare stuff relatively easily. So we're keen to be adventurous and innovative, and we'd like you to be that way too. So HEE are very happy to look at their apprenticeship scheme supporting new types of workers. So watch this space.
Can I just say one thing about retention, which is I was interested to hear that we have a much greater problem with retention in mental health trusts compared to acute trusts. And yet, you know, having worked in an acute trust on the medical and surgical wards, Helen, you were there with me at the Royal Free in London, you know, it's not a walk in the park in our acute trust. It's not like, oh, the easy jobs are over there and it's really hard in mental health. So I think this work that NHSI are doing to try and get under the skin of what will help people stay, how do we make jobs more attractive? How do we support people? How do we prevent burnout? I think the retention piece is critically important. I'm a particular fan of peer support workers as well, if I can declare that. We have something like 45 paid peer support workers in my trust, where I'm chief exec, and right across, that might be into addiction, dementia care, on the acute wards, in prisons, in a whole range of services, and they are an amazing element of our workforce. I would love to double and treble the numbers of peer support workers in my own trust with a proper career structure, proper training, proper development. I think I'm so glad you mentioned those, because they're my big passion and I forgot to.
I should say, I used to do NICE guidelines, and I remember on one NICE guideline, I won't say which one, we started off with 2 service users, a carer, and 12 professionals and academics. By the end of it, we realised they were all service users. So I'm very much behind peer support workers. I think an awful lot of us come into mental health probably because of personal interest. So why make that a reason not to?
Thank you both. Claire, you'll be pleased to know that our recruitment to the MBU, we heard first thing this morning, is going really well, including peer support workers. So some good stuff going on locally. Right, the next question. What can be done nationally to encourage health professionals to recognise the role of carers and work more closely with carer support organisations? Who'd like to take that?
I'll say a little bit and hand to Tim. So I've worked in mental health for 35 years, and I think the issue of carer engagement, carer support has absolutely been an issue throughout that entire period. And every now and then I think we glimpse real success around proper support and engagement. And then I hear issues that have cropped up for years, such as patient confidentiality and what carers can and can't be told, and how still across the country I'll find examples, in my own trust included, where a team will stop talking to a carer because they've been asked not to share information, and yet it's still the very carer that this person, maybe an adult, will be discharged home to, who'll be there for life when we've retreated back into the woodwork. So I think that the most valuable thing we can do is develop really great local networks and engagement and local understanding about what is our local plan, and put carers in a position where they can hold Helen and you and the rest of the team to account. You know, more carer training, more carer support networks, because I think carers are some of the most resilient people I've ever met. And if you can create conditions for them to be together and contribute to how services develop, they bring phenomenal expertise, but also in doing that, it's also quite a supportive thing. So I think you have to attack this problem from all angles. I wish we'd go faster and better. I see a hand up over there.
Okay. Have we got a microphone? I know we've got a lot of carers here today, and perhaps that's where this question is coming from. The mic's on its way. Here it comes. That's it, Emma. If you could keep it brief, that would be helpful, please.
Thank you very much. I'm a carer. I'm also part of Medway 5 Carers Group. There's a couple of questions I want to ask. I care for 3 people, and you said there's 150 beds, more beds. Whereabouts are those beds? Because I know my daughter's been in hospital 4 times and 2 of them been out of the county. So I'm interested to find out. I'm not saying that she's going to go back in hospital, but where are those beds located? Secondly, is when my wife had a relapse, she was taken to the hospital. The police said that she's got to stay in there until she's been medically fit to go home or what have you. And my question is, she was classed as medically fit at 3 o'clock in the morning, but in my view, to keep my family safe, I think that my wife should have stayed in hospital to see the crisis team, because she's not really medically fit if she did what she did. And she should have saw the crisis team or someone like that.
Thank you. The extra beds question?
So just on the extra beds, can I please, through you, Helen, say exactly where they are? Because we're expanding some units and opening others completely from scratch. So whilst I know off of the top of my head where some of those units are, I don't know the total list, but what I can do is get back to the office later today, and will you, Helen, make the contact and circulate that to anyone else as well who wants to know? On the medically fit, I feel I should hand this to you, Tim, for any view you may. Obviously, we can't talk about the individual case, but what does good look like in an A&E department when someone has perhaps turned up with self-harm or with an issue?
Okay, my son is a junior doctor working in trauma care, not psychological, but physical trauma care. And he says it's absolutely routine that junior doctors do not put anything about mental health in the notes because they don't actually grasp much to do with mental health. And we're both on a mission to make that change. It's going to take a long time to change it, but we really do want that to change. When somebody's assessed for their physical health, they should also be assessed for their mental health. There shouldn't be a little, an afterthought. If you think that 1 in 4 people at any one time, not through your lifetime, but at any one time, 1 in 4 people will have a mental health problem, that suggests that and the truth is you're much more likely to have that if you've got a physical health problem. So anyone who goes into A&E should be assessed for their mental health. And that's what the NICE guidelines make absolutely plain. You should be triaged for your mental health at the start. I'm also a carer, as is my sister, and you do get totally fed up with people telling you they can't tell you anything because of confidentiality. It's just, you just think, and if they're saying that, to me, and I don't go around going, oh, and by the way, I'm the National Clinical Director. But you feel like it, you think, oh, for God's sake. Now, I do think carers are, I'm bound to say this being a carer, I do think carers are a real key to a better future. If you look across the whole of mental health, which I've done with doing 30-something NICE guidelines, you begin to realise that actually carers are a really important part of the treatment programme. And the more severe the problem, the more likely carers are to play an important role. And that's openly acknowledged in early interventions, but equally, you go to ADHD, conduct disorder, autism in kids. There's always parents being involved as a key step in helping those kids. And I would go so far as to say any significant mental health problem involves all of us. And if you help all of us, not just the individual, you get a better outcome.
Thank you very much. I'm being told we've got time for one more question. Is there another one there? Oh, it's gone. Oh, I beg your pardon. It's from the floor. There's someone waving. Hello, who's that? The mic's on its way, Roger. Just give it a second. It's there.
Thanks. Okay. Can you hear me now? Yeah, name's Roger Hurst. Tim put up a slide which said inadequate housing provision. We have a briefing note here which refers to innovation in housing, care and support. One of the areas that we've talked about this morning, which is acutely relevant, I feel, in a time when we have an increasing ageing population, is depression, anxiety, loneliness, and all the issues that surround elderly people who are cut off and isolated from their community. Not all those people want to move into a block of flats which contains yet more people of a similar background who are also elderly. They want to be part of the community. They want to move within the community amongst children, families, with shops and all the provisions that they've grown up for. If you look around Kent, because we have very expensive land, there is no developer who is building bungalows or appropriate single-storey housing provision for older people. Consequently, all that housing stock where people would like to downsize is unavailable to families who would love to have a family home. And consequently, we have a situation where local authorities are unable to enforce that new developments include appropriate housing. The chair of Maidstone Borough Council recently said in reply to queries about why aren't any of the new developments around Maidstone including provision for, say, bungalows or appropriate single-storey housing, it's impossible to get developers to come forward with plans because they want to maximise profits, they want to maximise the amount of units they can squash onto the land. In the recent housing papers and proposals on planning that have come forward from the government, there is a, how can I say it, almost a whitewash attitude of it's down to you lot in local authorities to do something about this. Up north, maybe they can, where land values are cheap. Down here, commercial organisations, not unreasonably, want to make profits for their shareholders. They're not interested in developing communities. I'd like to know what your influence you have had with the government, and I'd like to know how you will put pressure on government to ensure that adequate housing for the elderly is provided in all new developments so that we don't end up at a situation where we have the elderly shuffled off to ghettos and the remaining new communities purely for new families.
Okay, let's hear what, there's an awful lot in that question.
Okay,
several questions.
Now,
so if you could pick out what you think you can...
Okay, the reference to housing in my presentation is about if you're bringing people back from out of area placements, it's often a rate limiting factor. Now that's also true for running acute and crisis care. That once somebody's in acute care, it's not uncommon they lose their housing at that point. So the way I've dealt with that in Sheffield is that we formed a really, really fruitful partnership with South Yorkshire Housing Association. And instead of us discharging people to the easiest housing to get, which is in the drug-fueled, gun-toting areas of Sheffield, instead, they managed to find some really quite nice housing in places which didn't threaten people in that way. So now there's still a shortage of stock even in Sheffield where land is cheaper, and we're reaching a limit to it. But that's the main issues I was making about mental health. But Claire, do you have more?
The only other thing I would add is, I know I don't want to be overly simplistic, but sort of somewhere to live, someone to love and something to do, broadly speaking, defines most of our lives. And having properly somewhere to live is clearly really important. We've tended to focus more, because it's our remit, on treatment services and what world-class treatment services look like. But as I said at the beginning of my talk, I'm really, really clear that people need cross-societal ownership of what makes for resilient, healthy communities. One thing is for sure, it's something like 1 in 4 children born today will live to be more than 100. They'll be living with complex comorbidities, they'll be living with memory, anxiety, depression, physical health problems, and society as a whole is going to have to reorganise itself, not just the NHS. And I think it is for you locally, just as it will be in every area, and the government nationally, to ensure that the right kind of housing in the right place with the right kinds of protection is available. But I'm not going to pretend that the NHS can do that alone, or that I have some great power to solve your local housing problems. You've clearly tried more than I. I did just want to go back to the gentleman over here, if I might, sorry, which was just on A&E, and we won't know, and there's not time to know, but I would just say that one of the reasons I was so delighted acute trusts were here today is there will be people who come to A&E in distress with both physical and mental health problems, and just because you're physically cleared doesn't necessarily mean that your psychological needs have been tended to. Where people are well known to services and are local residents and permanent, maybe with a relapsing condition, it's the hope, I think, that we have that well-grounded population health with plans for individuals that have long-term needs, so that you know and you agree what's going to happen if there's an A&E attendance to somebody who perhaps frequently has to come or has that need. Agreeing those plans up front with the carer, with the patient and with the professionals both in A&E and mental health seems to me to be absolutely one of the important tests of whether we are finally treating the whole person and thinking in a forward-looking, planned way about their needs. And I did just want to come back to that, gentleman.
Thank you. Thank you.